Dr. Foluso Fakaridi, who grew up in Nigeria and immigrated to America as a young teenager. He attended college in New Jersey where he obtained a Bachelor of Arts in Biology and a minor in Economics from Rutgers University. Dr. Fakaridi received his medical degree from Robert Wood Johnson Medical School in Camden, New Jersey. He completed his internship and residency in internal medicine at New York Presbyterian Weill Cornell Hospital. Dr. Fakaridi returned to New Jersey to complete fellowship in cardiology, interventional cardiology, and endovascular intervention at Cooper University Hospital, Camden, New Jersey. During his fellowship, Dr. Fakaridi was honored with distinction of Chief Cardiology Fellow. Dr. Fakaridi specialized in preventative cardiovascular management, women's heart health, and catheter-based procedure focused on coronary diseases and PAD. He has advanced technical skills in limb and salvage and utilizes advanced minimal invasive techniques in treating patients with peritoneal arterial diseases. He is also a key opinion leader in the treatment of PAD using various access techniques. In 2015, Dr. Fakaridi started Cardiovascular Solution of Central Mississippi with a mission to educate and to provide access, quality health care for all. He has become a national voice in the fight on the impact of health disparity in underserved communities. He is an active faculty member on multiple advisory boards for many devices companies. Dr. Fakaridi has provided multiple keynote lectures on eliminating disparities on local, regional, national, international platforms. Ladies and gentlemen, Dr.
Good evening, everybody. How y'all doing? Y'all doing all right? I just want to commend this young lady for exhaustively and precisely going through all that just to say, and I'm going to summarize it for y'all because there are kids in here. I am a heart plumber. I'm a vascular plumber. If you got poor circulation, if you got a heart attack, if you had a leg attack, or you're threatening to have an amputation, I'm the kind of doctor that you come see to prevent that or to treat it, all right? So just want to thank, first of all, we thank God for this event. We thank our sponsors and AKA stars who are here and hosting this event. The President, Mrs. Williams, thank you very much for the privilege of invitation. I'm very passionate about this topic. I am a trained interventional cardiologist, meaning that my job is I'm the guy you call when you need something done after you have a disease. But my passion is to prevent y'all from having to come see me in the first place. As much that is counterproductive to why I was trained, if you understand the trajectory of how heart and vascular disease has impacted the Delta, especially Highway 61, then you'll have a newfound appreciation for why events like this should not just be held on February, and why we should not just have a heart health month, but a heart health day every day or 365 days of the year. Number one killer of both men and women is cardiovascular disease. Not heart attacks, cardiovascular disease. What is that? Now, how many of y'all have a family member? Just raise your hand if they've had any of the following. So raise your hand as I say it. If they've had a heart attack, raise your hand. If they've had poor circulation or an amputation, raise your hand. If they've had congestive heart failure or fluid around their lungs, raise your hand. If they were born with a hole in their heart, or they were told they had a congenital heart abnormality, raise your hand. If they've had an irregular heart rhythm, raise your hand. If they've had a clot in their lungs and their legs, raise your hand. If they've had a history of anything wrong with the heart valves, any of their heart valves, a murmur, anything, raise your hand. If they've had any problems, all right, with any of their veins, Anything with veins. Any woman in here that has varicose veins, raise your hand. Now, I saw hands go up, and probably over 50% of the room at some point. All that comprises of cardiovascular disease. So it's not just the people that you see or the men that you see clutching their chest, all right? So we need to understand why that happens, why are we disproportionately affected here in the Mississippi Delta, and what we can do about it to treat it, all right? And to prevent our family members from having that. 1 in 3 women in this room will die of a heart event. 1 in 3 women will die of a cardiovascular event. That's your mother, your sister, your friend. Just look around. 1 in 3. 1 in 4 adults in this room will die of cardiovascular disease. That means 1 every 36 seconds or 1 every minute, we're going to lose someone due to cardiovascular disease. That is worse than all cancers combined. But we fear cancer more than we fear cardiovascular disease. So that issue has to do with awareness, but also it has to do with the mindset that we have to take it very seriously. It's not just in February we take it seriously, all year round. And what's sad is that 80 to 90% of it can be prevented. If screened early, if measures are taken appropriately, and if you see the right person that can provide quality care. There's a difference between access to care and access to quality care. Always remember that. So why is it so prevalent amongst us? Well, unfortunately, it disproportionately affects African Americans. If you look at the risk factors, high blood pressure is one of the risk factors. Can anyone guess which state has the highest rates of hypertension in the country? Highway 61 is the stroke belt of the country. Why? Because of high blood pressure. Highway 61 is the dialysis belt of the country. Why? Because of risk factors, right? Highway 61 is the amputation mecca of America. But why is that disproportionately affecting one region, as I call the amputation lottery? Or why does it disproportionately affect a community that is more predominantly of one race than another? So these are risk factors that we have to address. They are systemic issues in play, but also they are risk factors that we need to address. And which ones are preventable and which ones are not preventable. We have to address those as well. So plaque buildup. Plaque is the buildup of fat and cholesterol in your body and calcium. As we get older, it leads to the narrowing of the blood vessel, and that is known as atherosclerosis. That process can be accelerated by certain risk factors. Age. As we get older, anyone over the age of 45 with either the history of diabetes, high blood pressure, high cholesterol, you're at risk of having atherosclerosis at an early age. If you have a family history of heart attacks, meaning your mom had a heart attack before the age of 55, or your dad had it before the age of 50, you're at risk. If you're an African American, you're 1.5 to 3 times faster of developing plaque in your hearts and your legs than a Caucasian counterpart. If you are Hispanic, you're the same rate, 2 to 3 times faster. If you're a Native Indian, Native American descent, same thing, 3 times faster, all right? But there's also something wrong with Mississippi. We have the lowest number of physicians per capita. What does that mean? We have the lowest number of not only primary care physicians in the country, but we have the lowest number of specialists in the country. Now, whose fault is that? It's no one's fault in this room. The healthcare system is fractured and it's broken, whereby the average age of a cardiologist in America today is 56 years old. We have a health trajectory whereby the year 2030, 1 in 3 kids in this room, or 1 in 3 adults in this room will either be pre-diabetic or an adult will be a diabetic. So who's going to take care of the heart and vascular risk factors of these patients as they get older? So what do we have to do, or how do we empower ourselves? How do we get informed to transform ourselves? We have to understand what these things are and what are in play. Number 1 is your dietary risk factor. That is the number 1 preventable cause of death in America. You want to write it down, you want to jot it down. And I'm very serious about this topic because we have a disproportionate amount of fast food restaurants around versus healthy choices around. And that to me is either something is in play there or that we are just not aware of that. So when I say the number one risk factor that is preventable, meaning that what you eat and what you ingest can save your life. Sugar is the new tobacco. What do I mean by that? Now, I'm about to get some stares around here. Sugar is the new tobacco. And y'all know what I'm talking about, right? Sweet tea, right? Sweet tea. It has to do with what we ingest and has to do with the term moderation. I'm not saying I'm perfect. I'm not saying you all need to be perfect. But if you drink more water in your lifetime or this week than anything else, any type of juice, any type of soda, any type of pop, you are actually making the right strides. In terms of diet, write this down, y'all. The one diet that cardiologists will approve, and the only diet I can approve and stand up here to tell you that I can say is backed up by my board, the American Heart Association or American College of Cardiology, is the Mediterranean diet. I cannot speak on any other diet other than that. Why? Because that is what our guidelines recommend. I know there are other diets out there. I know some of them are proven. Some of them act in the short term. Some of them act in the long term. But I'm just here stating the facts. And the fact of the matter is the Mediterranean diet, if taken and adhered to properly, has been shown to reduce your chances of dying from a heart event by at least 35 to 40%. All right? Blood pressure. Any of you have high blood pressure or know someone who has high blood pressure? All right, good. Any of you that ever go to see a provider, and you go to see a provider just one time, one shot, and they tell you your blood pressure is high, do me a favor, tell them that you want to go home and check your blood pressure for 5 days and take an average of your blood pressures at home. Do you know why? Where's the worst place to check your blood pressure? Alright, yeah, amen. I mean, by the time y'all start saying, how do I pronounce his name? I gotta go see him, I gotta pay what copay? By the time you gotta wait and you got appointments to make, and then the text will come and take you to the room, and you're sitting there still waiting, and the kids are calling your phone, like, I'm hungry, and blah, blah, blah. And then we take your blood pressure, and it's a 160 over 50. And then I walk in and say, hey, ma'am, here's the medicine. Now, go home, check at what we call ambulatory blood pressure readings. Check your blood pressure. Average 2 to 3 readings a day for about 4 to 5 days. And have a log for about 4 days to 5 days and bring it to your doctor's office. Because if you have a normal blood pressure, that saves one medicine, that saves money in the bank, right, that you can use for something productive, and that saves your outcome because these medicines have side effects. I get it. I understand. All right? So, dietary risk, blood pressure. What's the third thing I'm going to talk about? High cholesterol. Some of it is genetic and some of it is what we ingest, right? And some of it is side effects of other things. But the thing about high cholesterol is there's something, if you're between the ages of 40 and 80 years old, all right? There's something called your pooled risk calculation score or equation score. P-O-O-L-E-D, pooled risk calculation score. That's something that we use to determine what is your risk of requiring a cholesterol-lowering drug that will save your life if it started on time based on your good cholesterol and your bad cholesterol and your total cholesterol. Look at all those numbers, okay? That's something that y'all need to kind of have in the back of your mind as you approach those ages. But at what age should a young person check their cholesterol? Any teenagers in here? Any young kids? Yeah. So at the age, once you turn, between the ages of 21 to 25, you must have at least have checked your cholesterol once. At the same age, every woman in that age, any woman who's over the age of 18, make sure you check your thyroid function once. Do you know why that's important? Because that thyroid hormone regulates cholesterol and other things as well. And while we're still on that topic of women, there comes an age where you have to know what ages that your moms went into menopause. Why is that important? 5 years before your mom went into menopause, you, meaning the daughter, is at risk of not only going into early menopause, but there's something that happens with menopause. You lose the estrogen protective effect of having any heart event, meaning that estrogen is protective against heart disease. You have a lot of estrogen, it protects you from heart disease. That's why young ladies in their 20s are not getting heart attacks. The only exception are smokers. If you smoke, your body doesn't care about how much estrogen you got. You're getting a heart attack. And the truth of the matter is, I'm sending 30-year-olds to have bypasses these days. And most of them are smokers. So we're going to get to nicotine later on. But the point is that you lose the estrogen protective effect around 40 years old, 45 years old, and some of your symptoms become subtle. Tired, fatigue, palpitations. You feel like, you're losing your mind. You feel like, listen, I get tired easily. And then you'll go see all these doctors, and everyone's running all these tests, and then some will be diagnosed with fibromyalgia. Some will be say it's lupus, but it wasn't diagnosed by a rheumatologist or a lupus expert. They'll come in and say, well, my primary care doctor says my vitamin B12 level, or they're giving you shots every week. Like, no. These are things that have to be addressed, and it's a discussion that your heart specialist has to have with your gynecologist. Because some of these replacement therapies have been shown to be protective, and some of them have been shown to be destructive, okay? So that's something that you have to keep in mind. So remember that. Your body mass index is something that we have to also talk about tonight. I'm very, very sensitive about this topic. Why? Because never go into a room predominantly filled with women and start talking about weight and BMI without being sensitive, man. And especially any man who wants to go into the medical profession, they will knock you out, all right? So this is all I'm going to say. Whoever came up with the BMI obviously was not an African American. Why do I make that point? And I'm saying this with a straight face. You know why? Who knows why? Right? What does it calculate? It calculates a ratio, right? But you understand that that waist to hip ratio too that's included, it varies across racial and ethnic lines. There's some people who are, thick bone, and some people are not. They're skinny, right? And that's genetically, and that goes way back. So if you're gonna say everyone should look a certain amount of weight and within a certain BMI, it's not taking into factor that some people are just genetically predisposed not to look like that, all right? So what you take into account are the whole totality of the picture. So your BMI, yes, there's a certain BMI that we watch. We always also say between 18 and 25 is a normal BMI, and anything between 25 and 30, you're overweight, and anything over 30, you're obese. Well, what I'm going to say is that based on that, 52% of African American women in this country, 52% are classified as overweight or obese, based on that. You know what that does? That puts them in a category of having a higher chance of what we call metabolic syndrome. I'm going to get into the weeds of that. But the equivalency of having a heart attack if you have metabolic syndrome is the same as someone who smokes 2 packs of cigarettes a day. And that's unfair. So we have to look at ways to address our weight, but do it in a way that is not destructive, do it in a way that's informative to the patient, do it in a way that it not only affects the patient, but affects the generations of women that are going to come through that line of family, right? So what I have people do is that know your dietary risk factor, know your blood pressure, know your cholesterol, know your BMI, know if you have nicotine exposure, meaning that does anyone smoke, does anyone vape, does anyone chew? Because all that reduces your life expectancy by 8 years. So if you know anyone who smokes, it's very easy in terms of the solution. Just grab he or her and say, can you stand up and look at the most precious thing that you value? If it's your kids, line up all the kids in front of them. And this is what I tell, because I do this in my clinic. Bring your kids to your visit, and I want you to look at them and say, I'd rather smoke this cigarette than spend 8 years longer with you on this planet. If you can do that in front of your kids or your precious loved ones, I will never harass you again about smoking tobacco or about dipping or chewing or vaping. But if you cannot, then you have a discussion to have, because your rate of plaque buildup is 3 to 4 times faster. If you're a woman, your rate of a heart attack is faster than a man if you're a smoker. So you lose all that protective effect, and that's why younger women too, again, a lot of heart attacks. You hear about it now in the news. The younger women who are having a lot of heart attacks and going for stents and for bypass surgery because of that. In addition, we have to look at physical inactivity. What does that mean? How much exercise are we getting in a day? Physical inactivity has been a discussion that we in the medical field have really struggled with over the last couple of years. And unfortunately, they have ranked states by the most physically inactive states to the most physically active states. Mississippi ranks #1 as the most physically inactive state. All right, what we're going to do about that? That's why kudos to this event, because what you did was you had an event, and the first thing, even before I came up here, we said, listen, let's go walk. Why is that important? Well, I have some sobering statistics, which are good, actually. I mean, sobering in a good way. Weight loss of 5 to 10% leads to improvement in all of those risk factors I just mentioned, and decreases your chances of death by just losing 5 to 10% of your weight. It decreases your chances of death by 30 to 40%. Just that, all right? How many of you know people who call the hogs or who snore? Yeah, you know there's a term for that. It's called sleep apnea, right? I don't know if you know this, but people who have sleep apnea, majority of them are either going to die from a heart failure, meaning their heart is going to give out, so you'll hear that they just died overnight because their heart got weak, and then they had irregular heart rhythms. But some of them also would have high blood pressure that's undiagnosed, that's untreated, and despite all the medicines in the world, it doesn't work because you're lacking good oxygen that needs to have good functioning and brain supply. So a lot of them fall asleep during the day. They feel restless when they wake up. They don't sleep right. You sleep 6 hours and you felt you only slept for 2 hours. They're cranky a lot during the day, and most of them just get somnolent on you. When you're talking, it's like, you're talking to someone who's sleeping all day. So that's one. But if you treat the sleep apnea 80% of the time, they'll have more oxygen in their lungs, they can exercise more, they won't require any more medications. So therefore, their blood pressure will come down and their sugar levels come down as well. So diabetes and our physical inactivity that leads to obesity are the two most, I would say, prevalent and the most dangerous risk factors that actually affect people, not only here in the Delta, but nationally. Those are the things that keep me up at night. Because I know what sugar will do to you and your risk of plaque buildup. I know what being physically inactive will do. So how do we counter that? We gotta eat right? We gotta exercise. Here's some of the things about exercising. You decrease your risk of a heart attack by doing the following. If 50% reduction by just walking 30 minutes a day. 50% reduction. 80% by vigorous activity once to twice a week. All right? That's good. I'll take that. 90% by vigorous activity 3 to 4 times a week. And 98% reduction in a heart attack 5 to 6 times a week. So what is vigorous activity? It's not walking the halls of Walmart, y'all. So I don't want to hear that we're going to walk Walmart and that's vigorous activity. No. Let me define what that is, because I wrote this down because I knew that question would come up. You race walk. So you race walk, right? You jog, you run, you swim laps. People like to swim. Some of us, I suppose most of us in this room might not love to swim. Aerobic dancing. All right, we'll figure. Bicycle, you bike 10 miles an hour or faster. If you jump rope a lot, that's vigorous activity. If you hike or you walk uphill, that's vigorous activity. If you do heavy gardening, people like to garden heavily, that's vigorous activity. And then if you play tennis, not double, singles, that's vigorous activity. And I mentioned jogging and running. Yeah, so those are vigorous activities. If you do that, then you can reduce your chances of having a heart attack by as close as 98% by doing that 5 to 8 times a week. And one thing that we have to start teaching our kids, and everyone in this room must learn how to do, is CPR. I've seen some young people die because they had an event at home and no one knew how to do CPR. So we need to start teaching all our kids how to do CPR. It's very easy. Everyone used to just, it's can sit down together, watch YouTube it if you want. Go online. It's as easy as it gets. But learn how to do CPR. And learn how to avoid some of those modifiable risk factors that I just talked about. Lastly, let's talk about the social determinants of health. All right? Because this is, so cardiovascular deaths have decreased by 32% for the last 20 years, meaning that people are actually have lived longer. But the question is, have people in the Delta lived longer? No. So how come? Here's why. It takes about 25 years for a state like Mississippi to catch up to states that have benefited from all the improvement and longevity in lifespan. So if you were to compare a state like New Jersey to Connecticut or New Jersey, it takes about 25 years for us to catch up to where they are. So when we implement policy, when we implement drugs, when we implement cost initiatives, on a national level and say what happens in New Jersey or what applies to New Jersey or Connecticut also applies to the Delta, guess what? It's not right. It's not fair. It's not fair to the people who are here. It's not fair to the history of the Delta. And so that has to be addressed. And that's why I speak about this topic nationally. There has to be what I call paradigm for parity. There has to be something that is fair and just to this place and is applicable just to the issues that pertain to the Delta itself. And once that's rectified, then we can have a level playing field to say now we can adjust it nationally. Number one. Number two, access to quality care. Whenever you're unhappy with the care you're getting, seek a second opinion. I'm tired of all this yes sir, yes ma'am all the time. I'm sorry, Southern hospitality is cool, but not when it comes to heart health or anything else. Go somewhere else. Even if it's with me, I really don't care. If you do not like how a doctor actually comes to you and talks to you about life-saving therapies or strategies, seek a second opinion. You have that right. Don't get stuck in one place because your outcome can be determined, and unfortunately, it can lead to a bad outcome. And a lot of family members have lost dear ones because they've just been stubborn and they don't know any better. You don't know what you don't know. So we need to be informed to be transformed. We have to seek the best. Just because we're in the Delta means that we should try and get the best quality care. And we should encourage our policymakers to try and see how we can incentivize doctors to come to the Delta. Because as I've said, we have the lowest number of physicians per capita. There's a national shortage of primary care physicians, and our specialists are getting older. If you look at the average age of a cardiologist, like I said, it's 56 years old. What happens in 20 years from now? How many cardiologists are we going to really have in the Delta? So I thank you for the privilege of invitation. This has been informative. Please ask questions and enjoy the rest of your night. God bless you all.